Welcome. We'll be getting started in just a few moments. We'll be getting started in just a few moments. We'll be getting started in just a few moments. Welcome, everyone. I'm Liz Whitehead, Managing Editor of Events at U.S. News and World Report. We're here today to explore how hospitals are taking on shortages and operational challenges. Today's webinar is part of the U.S. News Healthcare Tomorrow series, where we take a solutions-oriented look at some of the big issues facing hospital and health system executives and other industry leaders. You can find more details about today's speakers and what's ahead at usnews.com/healthcare of tomorrow. Now, before we get to our panel, a couple of quick notes. We are recording video of this webinar, and we will be making that video available on demand for registrants. We're also simulcasting from the U.S. News Facebook, LinkedIn, and YouTube pages. We welcome audience questions throughout the hour. If you have questions, please type them into the Q&A feature in Zoom on your screen. Our team will review and try to give voice to some of them over the course of the discussion. Now I'm pleased to introduce our panelists. They are Nasheen Ahmed, Director of Supply Chain Optimization at Cedars-Sinai, Michelle Hood, Executive Vice President and Chief Operating Officer of the American Hospital Association, Kristen Miles, Senior Director of Healthcare Supply Chain Product Strategy at Oracle, and Jeffrey O'Brien, Chief Operating Officer for Dartmouth Hitchcock Medical Center. Now I will turn it over to our moderator, Michael Morella, Managing Editor at U.S. News, to lead the conversation. Michael?
Thanks so much, Liz. Thank you to our panel and to our audience for joining us today. We have a lot of ground we want to cover, so I want to jump right into it. But before we do, could each of you help us sort of set the scene? You know, reports are saying that hospitals and health systems are facing a lot of the same challenges that are affecting many parts of the economy: rising costs, disruptions to supply chains, workforce turnover, and burnout. Could each of you briefly describe what you're seeing at your own institution or from the members and clients that you serve? And I'll add one more ask as we go around the horn. Could you help our audience understand your roles at Cedars-Sinai, Dartmouth Hitchcock, Oracle, and the AHA? Nasheen, could we start with you?
Of course. Good afternoon, everybody. I am responsible for leading the end-to-end tactical and strategic decision-making at Cedars-Sinai and support supply chain. Part of that is the digital transformation that we're having at Cedars-Sinai, helping with the resiliency efforts, anything to do with analytics and setting up a digital platform. And where that's helping with all of the supply chain issues going on is bringing transparency to at-risk items. So our frontline workers or patients don't suffer. We're able to maintain the level of care we did pre-pandemic and not have to cancel any surgeries or push anything out. We're still #1 in California, yay. And we're #2 in the nation. So happy to help wherever I can with responding to the questions from the audience and our panels. Thank you.
Thank you and welcome. Jeff, how about yourself?
Yes, Michael, it's great to be here. I'm Jeff O'Brien. I'm the Chief Operating Officer of Dartmouth Hitchcock Medical Center. We are a 400-bed academic medical center located in Lebanon, New Hampshire on the border of Vermont, and serve a pretty wide geography of patients from all of New Hampshire, parts of Vermont, parts of Maine, Eastern New York, and North Central Massachusetts. We're an academic medical center affiliated with the Geisel School of Medicine at Dartmouth College as well. And because of our geographic location, I think that we have some unique challenges ahead of us. Early in the pandemic, we suffered like many of the healthcare systems across the country with supply chain. We had typically been running a just-in-time sort of inventory approach. And boy, that was turned upside down when the pandemic hit and forced us to get really creative, which we certainly can talk about through the course of today's conversations. We were really hit hard with regulations and nobody knew what the right thing to do. We were getting advice from the CDC, from the feds, from the state level. Local rules and regulations were laid upon us that we really sort of scrambled quickly to have to adjust to that. I think once we stabilized, things started to become clearer for us. But today we're still in the midst of lots of challenges around supply chain and the consequences, I think, of the pandemic around staffing and ongoing issues with the patients that are coming to see us today are so much sicker than they were pre-pandemic, and probably partly due to the delay in care that occurred over the course of the beginning of the pandemic. So I'll try to maybe touch on some of these points as we go through our conversation today, and thank you for having us.
Appreciate that, Jeff. Kristen, how about over to you?
Sure. Hi, everyone. I'm Kristen Miles. I'm the Senior Director of Healthcare Supply Chain Product Strategy here at Oracle. I'm really responsible for working with clients around the globe, making sure that our supply chain applications at Oracle really reflect and support the unique needs of healthcare. As we've, over the last several years, really had the opportunity to work with healthcare customers to understand where the challenges have arisen. And I think we all recognize that there's supply chain shortages. And while those continue, I think a lot of our customers have found opportunities and ways to solve those in really unique ways through various changes in processes and technologies. But what we're really finding is the supply chain staffing is number one on everybody's mind. And that trickles down right to every single department, including supply chain, which is causing them to then have to, they're still being tasked with saving money, right? And we are all looking to, bring in those savings and report those savings. But now these folks are having to do it with less staff. They're trying to find more efficient ways. And most hospitals have squeezed every single penny they're going to out of just the cost of the goods. And now it's time to find new ways to direct cost savings from a supply chain perspective through standardization, optimized buying processes, rebates, things of that nature. And they're being forced to do more of that with less staff. So super critical issues going on still.
Thank you, Kristen. Thanks for being with us. Michelle Hood, how about yourself?
Hi there, everybody. Glad to be with you today. As you heard from Liz, I'm Michelle Hood, Executive Vice President, Chief Operating Officer for the American Hospital Association. Our members are really, as Jeff said earlier, really suffering from a lot of instability, both operational and financially. Different than we were in the early days of the pandemic, but it seems like when we solve one issue, another one arises. We've seen, a tremendous impact of the cost of to care for patients increase dramatically, 20% overall on a per patient basis when compared to pre-pandemic. Huge increase in the cost of medications, 37%. And of course, labor, 19% from 2019 to 2021 for many reasons, which we can talk about as we go through today's webinar. So the financial instability is as critical, but significantly tied to, of course, the workforce issues that we are all challenged with. And I know we'll get into some more details there. As Jeff mentioned also, patient acuity has increased significantly. And as a result, length of stay has increased. So we've got this crazy time when all of our members' beds are full, but they're losing money. And they are really struggling to try to find the workers to take care of this huge increase in the number of patients hospitalized, not necessarily for COVID anymore, although many of the folks that are hospitalized for other reasons also have a comorbidity of an active COVID infection at the same time. So tremendous challenges, and I know we'll have a chance to talk more about that. So AHA, has been from day one working daily with HHS and all of its subsidiaries, CDC, FEMA, FDA, trying to prepare as best as we can to meet the challenges of the pandemic, and more recently with the White House response team, starting out early in the Biden administration on almost a daily basis to now a couple times a week checking in. But we're interested in a full society response to all these challenges and are trying to translate those member needs to our federal colleagues.
Thank you, Michelle. And I think you all did allude to a number of the challenges and the interconnectivity of those. I appreciate that point, which I do really want to kind of dive into more deeply. Let's start with the supply chain. You know, bearing in mind some of the challenges you've seen recently, either during COVID or even prior to the pandemic, how are you working to address those? You know, are there some specific innovations or new opportunities that you found maybe out of necessity or maybe that were in the works prior to 2020 that you could talk to us a little bit about that might be you know, instructive for members of our audience? Jeff, would you care to start us off?
Sure. You know, I think the pandemic really forced us to start to think out of the box. We quickly, you know, out of necessity, needed to move away from more of the traditional ways in which we acquired goods and services, typically through brokers. And instead, we were finding ourselves dealing directly with manufacturers. And we did both expand our list of vendors, but also we contracted at the same time. It was not unusual for us in the early phases of the pandemic to reach out to local companies to help us source things that they could produce locally. And for us, it was gowns, some face shields, simple things, lab coats that we just could not get early on in the pandemic. And conversely, we started to deal directly with manufacturers of goods. And instead of going through brokers where we would typically buy, I don't know, 1,000 boxes of gloves to keep us, you know, good for a month or so, we found ourselves needing to buy a minimum quantity of 33,000 boxes of gloves, which really created multiple challenges for us, including storage. Where do you put 33,000 boxes of gloves, right? And so we had to be innovative and partner with other healthcare organizations in our region to share those supplies across our different institutions. And we found that to be the key ingredient to make sort of dealing with manufacturers directly sustainable. You know, one really crisp example that comes to mind on the innovation front for supply chain work is what happened in our lab. Early on in the pandemic, we were informed by the CDC and others that one of the best ways to manage and control the spread of the disease was to test as many people as we could possibly test. The theory being that if people knew they were positive with COVID, they could self-isolate, protect others from getting the disease through spread, and certainly maybe tamp down the growth of the COVID-19. The problem was there were no test kits available. Manufacturers hadn't developed it yet. And our lab in work with our genomics team did an amazing job because they had about a year's worth of experience in developing their own testing mediums and materials that they were able to pivot quickly and get what I would call the basic foundational supplies, the testing system, and then the supplies to make the mediums that over a very short period of time, we found ourselves actually in the test making business by default. And not only did that help us serve our own patients, but the state of New Hampshire quickly latched on to that and said, you know, we need your help because you're creating these testing kits. Can you help process the results in the testing? Because right now we're only be able to do about 200 a day. And within a very short period of time, we were doing well over 1,000 a day by using the sort of the innovative approach that our own local team started to develop internally. Today, that continues. We continue to produce our own. We sort of augment it from time to time with now the manufactured test kits. But over the long run, we're still a big part of the state of New Hampshire, as well as long-term care providers who now send many of their test samples to us for processing. I think that these types of innovative and creative out-of-the-box thinking that we wouldn't normally have done in the past came out of necessity because we just needed to keep our operations going forward.
Nasheen, I know, you and your colleagues at Cedars-Sinai are leveraging a lot of new technology and digital tools, using data in compelling ways. Could you talk a little bit about that from a supply chain standpoint? And of course, anyone else, feel free to jump in after.
Of course. So adding on to what Jeff explained, Cedars-Sinai was facing some of the similar issues with back orders and declining fill rates. Our approach was a little bit different. Our executive team, very proactive and very involved. We restructured the supply chain organization. So I was brought on as part of the restructure about a year ago. Have the optimization team put in, have a specific resiliency department. So the people were mobilized to produce and be effective and run in a certain direction towards a common goal. So one was the restructure. With the restructure came the digital transformation because Cedars-Sinai Health System, having our hospital, Marina del Rey, our affiliations with Torrance and Huntington, everyone's on a different ERP system or an ERP instance. You have different data pockets. So part of that is bringing together and establishing a data integration layer, which is a single form of truth, because you need to be able to have one source of truth and be able to pull information very quickly. And traditionally, that's not been as robust in the healthcare system. So we did that. We used APA technology to build in workflows because finding out about a killed order or back order after the fact is too late. So how do you get in front of it, right? In traditional settings, you go through, your sourcing teams will go through 12 to 15,000 items and manually review it. By the time you get to it, the data is outdated. So we designed an in-house model using APA, which runs in a couple of seconds. We refresh it every week and it's targeted. So you have less than 100 products you're looking at, which require human intervention and an approach. So decrease the amount of time that you're spending on manual effort, put the critical items in front. We established from our resiliency team a communication path directly with the clinicians and the physicians. This is on back order, we can get a sub. This is what we're stocking. We used one of our warehouses as a tactical advantage for us during the pandemic and still are. And then the last piece is, how do you get visibility to stock levels across different nodes in your chain? And that's where we established CPFR, which is a collaborative planning, forecasting, and replan model. And we're working very closely with our key distributors. So those are a few of the key things that we did. And that's in line with not just the digital transformation, but mobilizing our people, because technology, after all, is a tool. And unless you have the people with the right skill sets driving the process, you can't really execute well. Hopefully that helps.
Nasheen, I think that's a great point too, right? It's with more technology forward kind of processes, you've got to make sure you've got the right skill sets in the right places. And I think we all recognize that the staffing pool is relatively shallow, and some of the folks that have been in our organizations for decades, right? They're having a harder time moving forward with our digital transformations that we're seeing in healthcare. And that makes it even more difficult because we don't want people to retire early out of frustration, and we don't want people to leave for a comparable paying job just because they're frustrated or don't know. So it's not only are we needing to embrace the technology, but we're also needing to learn how to educate across the continuum of learners. So that's another piece that I think is really challenging for hospitals today.
Michael, I'll just add a couple of parts, maybe looking forward a bit rather than backwards at the challenges, the many, many challenges we had during the pandemic with supplies. equipment and staff and beds and so forth. You know, one of the things that we're working on with our members and through our professional membership group that is made up of our materials management executives is to reimagine how it is that we think about the storage of supplies. We find that just-in-time inventory approaches got us in big trouble early in the pandemic. As Jeff said, we can't have every hospital in the country storing 6 months of supplies. It's impractical. So how is it that we regionalize those approaches? Certainly the need to diversify manufacturing sites. We brought a lot of things that were offshore into the US. Unfortunately, many of those folks are no longer or choosing to stop manufacturing of some of those supplies, and it's going back offshore, and that's a little bit worrisome. And so how do we incentivize that less of that dependence on foreign manufactured goods or the underlying supply of product necessary to make the goods. We are supporting and advancing technologies around reprocessing to provide us another area where we can shore up inventories when it's necessary to mitigate supply shortages. And we think about it as really building a national or maybe even a global control tower approach to better managing our healthcare supply chain, building resilience into that visibility, and using cloud-based technologies as well in order to prepare the analytics that can help us become more efficient and precise as we think about the future.
That's a very helpful analogy, Michelle, the control tower one. I think I'd love to just go around the group and get everyone's perspective on that concept of resiliency and transparency or visibility. I know you each alluded to it, or some of you alluded to it a little bit, but could you talk about how that's, how you're building towards and ensuring a resilient supply chain, and, how you're doing that while looking forward and also responding to the current moment, with the latest Omicron subvariant, upon us and just a very challenging couple of years. Anyone want to start us off with any additional points there?
Let me react to that a little bit. It may not be answering your question exactly how you asked it. However, I do think it probably lends a little credence. The work that Michelle just described about trying to get ahead of the supply chain challenges, or that curve, if you will, is so critically important, because as an operator of a hospital, running day-to-day operations, absent having that forward-thinking solution in place and working, tested and working, we are then reacting to every little problem in the moment. And I'll illustrate that with an example that I mentioned a moment ago: the sharing of bulk purchase supplies, while on the surface sounds great, but then you have to figure out distribution. Where do you store it? How do 3 hospitals, whether it be University of Maine, Vermont Medical Center, who are sharing in that glove purchase that I mentioned a moment ago, how do they get those, and where is it? Well, it happens to be we had to buy a warehouse in New York to actually store those. The thing is, when we're sharing products, we've learned from each other that not everybody has to evaluate those gloves, that we can now start to share in the clinical evaluation of products and services. And one institution can represent several. So in our case, it was not unusual in working with Maine and Yale and Vermont that one institution evaluated the gloves, another institution evaluated the masks, and a third institution evaluated the gowns, just on the PPE work. Today, we're faced with even a magnitude of problem in the shortage of contrast that is used in radiological exams, CT exams, et cetera, because there's one manufacturer of the contrast in China, in Shanghai, and when they had a COVID outbreak, they shut the factory down and Sure enough, boom, we didn't have any contrast to do the kind of work. And in looking at that problem, several organizations coming around it together can actually be much more efficient and faster to determine what are the alternatives. How do you set up a prioritization schedule for patients that are most vulnerable in needing the contrast for their study versus an alternative? And it's the collaboration that takes place in those kinds of situations that actually help us rise above the in the moment problem. Now, that aside, that's not sustainable. So the work that Michelle is designing of an I love that also, an air traffic control center, so to speak, for supply chain, I think is going to be a critical success factor for us moving forward for the next pandemic or the next crisis that hits us.
Yeah, Jeff, I agree with you as well. I think that it's going to be critical to also have technology to bring all the constituents together, right? To allow forward planning for not just the hospitals in a region or in a country or even around the globe, but then to communicate that need to manufacturers in advance and to begin to have a true understanding of where is this glove actually manufactured. If you had asked a hospital 3 years ago if they knew where things were manufactured, the answer is no. I think all of us as hospitals realize, oh, we didn't realize that a lot of our stuff came from Puerto Rico when a hurricane came and wiped it off the map, and all of a sudden we're all on allocation, right? So I think it's things like that that started to plant the seeds to, we've got to do better. We've got to understand our actual supply chain, stop relying on those intermediaries such as distributors, et cetera. They absolutely have value, but we need to understand the origins and what's going to impact their ability to procure our goods. So I couldn't agree with you more. I think it's collaboration, but we need technology to bring us together. And I think that's between the AHA and some of the other entities that are forward thinking and moving everything to the cloud, we have the opportunity to do that.
Yeah, I'll add one other ingredient to that. I love the idea of the technology, the analytics and the staffing and more in-depth understanding of the supply chain as a whole. I think there are also tremendous lessons to be learned from other sectors of the economy that manage really complex inventories much more effectively and efficiently than perhaps hospitals and health systems have been known to do. I had my first job postgraduate degree as the director of materials management at Emory University Hospital. And I did that. Our CFO said, well, I've got a vacancy and I just need you to step in for about 3 months after you finish your residency. And I did it for, 15 months probably. It was one of the most interesting jobs I've ever had. You get to see every single part of the hospital. But it's also so complex, from the relationship with vendors, distribution channels, storage, moving it within the organization, the whole idea of how do you go about selecting the supplies. I think there's just a lot we still have to learn and get better at as it relates to this, and lots of opportunity.
I want to talk about the people and workforce and staffing challenges, but I want to turn back to you, Nasheen, briefly. We have a question from someone in our audience who's asking if you could kind of share a little bit more about the resiliency department you alluded to earlier, kind of how, the scope of that, who's involved, how you approach that as a potential model for others.
Of course. So I work very closely with the executive director of the resiliency department. And that's because the resiliency team really knows their products, knows the critical side, right? I, on the other hand, am coming from a data perspective, coming from a tech perspective. And in today's age, you really can't have one without the other. So we complement each other for the better of the organization. That being said, most important thing is the internal and external communication. So the internal communication on how we operate is developing those models internally, right, that are customized, that help us focus our attention, and that we develop in partnership and work sessions with the teams on the business problems they're facing. Okay. And additionally, then we go out, which is the external communication piece, getting our key distributors. I know there was talk about direct buy versus going through a distributor, but realistically speaking, hospitals don't have enough space to store everything. And the lead times from a direct buy are much larger than a few hours from a distributor. So pulling them in is also part of the resiliency team's efforts. Along with our team, we have joint sessions, which is part of our CPFR planning. And we really get down to the visibility at the different nodes in the system, at their warehouses, at our warehouses. There's a very high level of trust and communication saying, okay, we don't have space to store this. Are you storing it for us? This is what our model is saying. In addition to that, we're going away from the traditional forecasting models, right? Most places have the 2 to 3 year seasonality curves, and then you say, well, this is how much we're expecting. With everything going on, that needs to be revisited. And your resiliency, your sourcing folks, or your frontline saying, these are, I believe, what the drivers are. Then you bring in your clinical teams and your surgeons. Well, what data do we have available? What parameters do we need to consider? So you've got that forecasting piece that's being adjusted, and we're leveraging the new APA tech that's out there. And then you have to bring in scenario planning, because you could, resiliency is also, well, if we implement something, do we have enough manpower? Do we have enough, have we thought through how we're gonna execute at a system level? Because data only tells you so much, and then it's the execution piece. If there's specifics, I'll be happy to answer them. I don't know if that addressed the audience question, so let me know.
I think that's very helpful. No, I appreciate it. And I do want to stay, you just mentioned another area that I wanted to ask about later, but I'll talk about now. The internal versus external communication and this idea of communications and transparency. Kristen, could I pitch this to you first? You know, how is, whether you're thinking about supply chain or staffing or shortages, operational challenges overall, how critical is transparency and kind of clear lines of communications, especially when you're working with partners across the system, across the sector, across a region?
Yeah, I think it's transparency kind of underlines or underpins everything that we do. And in healthcare, transparency doesn't seem to be something that's bubbled up to the top yet, right? When you're talking about transparency and pricing, as an example, we have an incredibly complex pricing structure not seen in other industries, with third-party GPOs and regional GPOs and alliances and purchasing coalitions, and plus I'm going to go do it by myself. And you can imagine that every single one of those touch points has staff, entire teams of people trying to just simply manage the pricing. So that becomes, in my mind, one of the first places that we could look at would be to create pricing transparency, to then flatten that and remove cost from every single one of the players within the healthcare supply chain. That's number one. The other piece is transparency in need. So as we talk about forecasting, right? And you know, Nasheen, you just kind of referenced that we're looking at historical purchases. That's not good enough. We need to be able to tell our manufacturers that we are in real time. Here's what we're using. Hey, here's our patient acuity. Our patients are sicker. Hey, we've had a tremendous, horrible fire that has caused an influx of burn patients, and we're going to need X, Y, and Z. And being able to send that in real time. Here's what we have on the shelf. Here's what we need. Patient diagnosis, patient census, how full are we? What is the acuity? What do we have for planned procedures? What do we have for planned visits within our physician practices? All of those pieces need to be communicated to manufacturers so they can start to do planning. And because we do such a terrible job at it, right? And we're mostly historic looking, all of us are scrambling every single time there's a shortage.
I'd like to add to that, Michael, if I may. I absolutely agree with Kristen that transparency is absolutely critically important for us to get ahead of the challenges that might happen in the moment. And yet we're faced somewhat in a little bit of an archaic system where when working through our group purchasing organizations, they like to keep things tight and not share information across the broad spectrum of healthcare because it might, they perceive, give them an unfair disadvantage or advantage, from a competitive standpoint. And so we are kind of at odds a little bit. We believe that being transparent and allowing the flow of information will actually make for a better healthcare delivery system. But in the current paradigm, we're kind of stuck in this transactional approach. And so I absolutely agree. But it's going to be a heavy lift to get there.
I agree, Jeff. I think that, one of the key pieces here is really having those stakeholders have some being able to get value, right? We don't want to disintermediate the GPOs. That's certainly not what I'm saying, I swear. But, having everybody to understand that the amount of effort that goes into tracking all of these different complex tiers and, do I have enough of, am I standardized enough to be eligible? And imagine the distributor having to manage that for every single one of their customers across all of the different manufacturers that you've contracted with, and throw in a regional GPO or secondary GPO, and it's mind blowing. And quite frankly, no one's very good at it. I'm going to be really honest. I think we've all recognized that, hey, at my hospital, I'm terrible at it, but when and the suppliers must be really good at it, and they're not. And it's incredibly arduous and expensive for them to do that. Now, there are other ways to still, for GPOs and others, to still add value and still to be able to get pricing breaks based on, rebates, based on volumes, other types of things like that. Being able to bundle capital purchases with supplies, creative ways that are not going to require these just absolutely mind-blowing number of staff to do this, and no technology in the world is going to make that better. I think we need to learn from other industries where transparency is okay. We can leverage marketplaces. We can, at the end of the day, I know that, we've had, especially in the implant space and things of that, like nobody wanted to really expose their pricing. But now we have enough data to say it doesn't really matter. If your implant reduces days on, patient stay days, length of stay, we get reimbursed and we're getting a pass-through for Medicare patients, great. Why not you let the facts stand for themselves and being able to price? I will tell you that when you look at other countries outside the US, they are paying significantly less for all of these things. And it's kind of what the market will bear. And there's a heck of a lot more transparency in these other countries. So I think we need to do a better job.
I want to turn our attention to workforce and staffing. And, you talked a little bit, several of you, about some of the challenges you're seeing there. And again, the fact that these are often interrelated challenges. Michelle, could I start with you, minding some of these challenges, which you're hearing from AHA members, what's working to address some of those gaps? And I know, for instance, you all have a workforce task force, a number of resources that you put out there. Could you talk to us a little bit about that?
Sure. So first of all, I think to start, our members are experiencing shortages in all jobs, entry-level jobs to physicians. And the forecasts that are out there are pretty scary as far as the supply expected over the next 5 to 10 years. So we have an urgent issue today, but this issue is going to go on for some time. And so we're looking for ways to relieve as much pressure as we possibly can today, but also to try to create more resilience in the system of training and retraining and reskilling our workforce on a regular basis, so as not to have to go through this again. Although I've been in healthcare for over 40 years, and we have seen a cycle of shortages throughout those 40 years. This one is really much more acute than any that I've seen in my career. We are working with our members on any number of approaches. We're trying to address the burnout situation so that we can recover our existing staff and not see the huge turnover numbers that we've experienced over the last couple of years. About 20% of our workforce has left the workforce within the last 18 to 24 months. And the turnover rates continue to be high in just about every category. So retaining our workforce, providing a work environment that is safe, first of all, and that is rewarding. And it's back to the reason that most of us went into healthcare. It's a sense of purpose of doing something that's really, really critically important for our families and our communities and the country as a whole. So, regathering that sense of purpose and pride that goes along with work, addressing the burnout and the mental health issues. We shouldn't be surprised that a good percentage of our workforce is suffering some sort of trauma related to the pandemic. PTSD and all of its symptoms and results is certainly there for us to see. We need to build ladders so that people who come into the workforce at an entry level can see a pathway, many pathways that they might travel throughout their career to continue to develop themselves professionally and not necessarily that they're going to stay with one employer for the entirety of their career. I think that's an unrealistic expectation, but if we can retain them in healthcare, that is a win for all of us. We're really looking at how we bring new skill sets to our frontline managers. We think those frontline managers probably were hit the hardest. Although I think our C-suite folks have shouldered a burden during this as well. Everyone has, but those frontline managers who all they want to do is staff their beds or make sure they have enough techs to take care of the patient schedule in the OR or in the radiology department. So they need new skills, as we introduce digital technologies and other technologies. We oftentimes think, well, of course, they'll know how to optimize those tools and those resources. Not true. And healthcare has been pointed at repeatedly over the years of not doing a really great job of continuous training. And education budgets are the first to go when things get tough, right? Everybody stops, and just does enough to get by. So we do have a navigation guide of resources that has been published for our members. It's on our website. We are issuing 3 different editions, chapters, if you will, sets of chapters. The next one comes out tomorrow. Wait, today's Wednesday. Today, it comes out today. And this one is all about technology and data and how to use data and analytics differently. There's some really fascinating things going on out there around capacity management and automating things. So AHA's role is really to scale those best practices as quickly as we possibly can to contribute to greater efficiency and freeing up our resources, our people resources to be at the bedside or in the clinic or where they're needed. So increasing use of technology, really increasing the flexibility of the work schedule and introducing the hybrid work model, using nurses, for example, who can maybe one day a week, they don't come into the hospital. They do discharge planning and chart review and other things that they can do from their home desk as easily as they can do in the hospital. So I could talk about this for the rest of the afternoon, but I'll stop there and let the others hop on as well.
That's very helpful, Michelle, and I appreciate you acknowledging those resources that are out there for those who want to learn more. Jeff, I want to turn to you just briefly and acknowledge, and ask really what's working for you, or what are you finding from a workforce development retention standpoint, especially in a rural area? Could you talk a little bit about that? We have audience members from all across the country, but I'm curious how things are in New Hampshire and the areas you serve.
Sure. So yeah, let me start by saying I don't think we've gotten it right. I think it's been a journey that we're still on in trying to get it right. And we don't have that silver bullet that solves this problem at our fingertips. And in fact, based on our geography, where there are certainly more trees than people in this region, we suffer, I think, in an exacerbated way what urban centers experience, and perhaps are amplified a little bit because we have such small numbers. The bottom line is, and Michelle, touched on it, we have a talent gap. There aren't people who want to work in healthcare, and it's compounded by the fact that we've lost a bunch of people who wanted to work, and there's not enough new people coming in who desire to work here. And I think Michelle nailed it when she said we've got to create this sense of purpose, recreate the sense of purpose for people to work here. But for Dartmouth Hitchcock, we suffer from many ailments. One is housing. There's just not enough housing to bring new employees to work here where they can actually have a quality life, and they're not traveling long distances to come and go from work each day. And corresponding to that is limited daycare if they've got families, because we're small. We're a smaller community, and we're spread out so far. The fact that what is so great and attractive about living here is also a deterrent for people who want to come and live here, because there are certainly limited resources. We've thrown a lot at the problem, Michael. I mean, we've looked at wage, we've adjusted wage, we have continual programs. And like I said at the outset, we haven't gotten it right yet, but we continue to want to get it right. We've hired 25% more employees in 2001 than we did in 2020. And we still have a 25% vacancy. We're a health system that has about 11,000 employees, about 9,000 work at the medical center that I'm the chief operating officer of. We've seen a 45% increase in open healthcare jobs in our region alone in the past year. No industry can sustain that. And as a result, we're hearing it and feeling it from our staff. The burnout is real. And the frustration is certainly there. And they're heroes. They really are heroes, not in the superficial sense of the word, but they're just working unbelievable. In order to support them, as an example, we stood up a program called DH Reserves, very similar to the National Guard and other sort of governmental reserve programs, where we took every non-clinical person and administrative person and manager in the organization, and we took them out of their role and put them to work in the clinical setting or in a service setting. It's not unusual today to still go down and see somebody who was a practice manager in an outpatient clinic actually working the dish line in the kitchen. It's that real for us here, and we continue to chip away at it. One area that is a real nugget for us is our amazing colleagues in HR have stood up a program called the Workforce Readiness Institute. And we actually started this pre-pandemic, but expanded it widely during the pandemic, where they actually bring in people who want to work at Dartmouth Hitchcock from the area, but don't have the skill sets yet to have the entry into a good paying job. And we have stood up programs around certifying for licensed nursing assistants, medical assistants, technologists and radiology, lab and pharmacy. And these are good paying jobs, and so we've been able to train and then onboard hundreds of new employees through the Workforce Readiness Institute. And it's a great model that I advocate others certainly to follow as well. This has been especially hard on our nursing workforce. And the whole nuance of hiring travelers is continuing to erode and contribute to the high cost of healthcare.
Kristen, do you have a point to add on that?
Yeah, thank you. So yeah, I couldn't agree with you more, right? The travelers, especially in rural areas, while it's an attractive place, the travelers get to see great parts of our country that they wouldn't normally see. It's incredibly expensive. And right now, I think just a requirement to do business. But if you think about the education, and Jeff, your program sounds amazing. When you want to hire more nurses, that means you need to train more nurses. And for a nurse to go and teach, she's going to take a pay cut, right? So it's not necessarily a very attractive opportunity. So we need better programs to incent people to teach and stand up additional clinicians so that we can drive forward. The wait list to be getting into nursing school is really long. And so we have this weird dichotomy of, we've got people who want to be nurses. We don't have any place for them to get educated, so we can get them out and providing care. So we need to do a better job in bringing it all the way back down to that level, I think.
Yeah, I just saw a number yesterday, Kristen, that just blew me away. 91,000 plus qualified nursing students were not granted admission last year because of lack of faculty or lack of clinical site. 91,000.
It's mind blowing. That to me is the underpinning of the issue, right? We got to do a better job of getting people paid a decent wage to educate these nurses, and finding the staff and the care sites to help with these clinicals.
So the American Organization of Nursing Leadership, which is a subsidiary of AHA and is housed here in our offices in Chicago, has a task force that's working on these very issues. Their first work product is scheduled to be published in September. They're working with the academic programs, but other things like licensure, which is a barrier to practice. And they have 7, as I think I said, 7 different work streams. So watch for that. It's a really active group.
Sounds great. Can't wait.
Oh, go ahead.
No, I was just going to say, I can't wait to read it and then to hear all about it. It sounds wonderful.
We've got about 10 minutes left. I want to try to squeeze in a few more questions, including some from our audience. Asheen, I want to turn back to you briefly. Whether it's thinking about staffing workforce or back to supply chain and some of the innovative work that you all are doing, are there other areas or ways that you are tapping or leveraging new technology, AI, data analytics, whatever it might be, to kind of drive optimization or operational efficiencies that we haven't talked a little bit about? I'm trying to think about some kind of broader lessons for the field and for the leaders in our audience.
Sure. So within Cedars-Sinai, I'm sure other health systems have matrix organizations where you've got IT that's separate, supply chain that's separate, and each department has different skill sets. What we did initially is there's a new collaborative model within Cedars-Sinai where we're pairing up my team along with EIS, which is the IT equivalent. And there's dedicated folks that support us, because your data scientists are part of that IT department, and they have that skill set in AI, in machine learning. They've got additional coding experience, but they don't necessarily have the business supply chain side. So then you've got folks which are supply chain and don't really have that IT. But my team has a little bit of that tech where we are the liaisons between supply chain and our IT department, and work very, very closely together to develop stuff that we can leverage on the business side. And that's that communication piece. I think in most organizations, your business folks have this communication barrier with the IT folks, and they're not speaking the same language. And we've overcome that here and have a very solid bridge and a working model that's really helping us drive innovation and helping our broader teams. As far as new tools. I mentioned APA. We're using software such as Alteryx within our departments, and that's because it doesn't involve heavy costs of ERP migrations and a lot of your resources being tied up in architectural redesigns. It's a lot more fluid, and you can design stuff on the fly and get workflows launched and data available to your executives in a very short turnaround time. So leveraging that on the AI piece, that's something I can't speak to personally, but I know that our IT folks are helping us on certain projects with that. So I'm going to stay off that topic, but yes, Cedars-Sinai does have a department that focuses and leverages that tech out there.
Question from someone in the audience. I'll just open it up to the group. Are there ways that health systems, hospitals are using electronic health records to improve efficiency in terms of staffing levels, or look for address those kind of gaps in supply chain? Kristen, you want to take that?
Yeah, I think so. I think there's a couple of different things, and I'm sure, Michelle, you've got some insight as well. But one of the ways is making sure that the EHR and the the EHR and the ERP are interconnected, and we're pulling all of that data and analytics. One of the things I was talking about before is demand planning, being able to look at procedures, preference cards. What am I going to need over the X number of weeks? Factoring in, a percentage of a margin of error for emergencies and add-on cases, patient census, the diagnosis, et cetera. And then I think the other piece too is really looking at ways to consolidate service lines. So being able to say, can I look at my demographics, and can I look to potentially move some service line, chemotherapy as an example, and knowing that I don't want patients to drive more than 30 minutes, right? And by doing that, am I still able to close a site or two, consolidate some of that? And then the other piece that I really think is super exciting is the hospital at home, being able to allow smart technology to be given to our patients and having nurses monitor from home. So they're looking for spikes in blood pressure or glucose or respiration, things of that nature, and being able to say, it's time for this infusion to happen. It's already been set up. The nurse activates it from where they are. So leveraging some of that IoT and technology to really help the nurses be able to manage better, give better patient care, but manage more patients at the same time, because they're not walking back and forth and tracking things down. So I think that's really exciting.
I want to try to sneak in one more question, and there's a lot of threads we could follow. Policy, more on technology, lessons from other sectors has come up. But I wonder if looking globally or thinking about things that maybe we touched on or didn't have time yet to touch on, are there other ideas or solutions, again, be it at the policy level, the partnership level, and so on, that you could share in the spirit of addressing some of these operational challenges in a forward-looking way? I know there have been a lot of lessons learned and talked about in this hour, but I want to give everybody the opportunity to just kind of talk and seize on, maybe one thing that could happen, or that you would hope happen that would really ease the burden for future pandemics, other future challenges. It's a big question, a loaded one. Who wants to take a first crack at it?
Well, I can take a first crack at that from a policy perspective. One of the things that we're doing is working with the federal agencies and the legislators around not putting back in place some of the restrictions that were in place pre-pandemic. So things that didn't allow for hospital at home and didn't allow for widespread use of telemedicine, didn't allow workers to work across state lines without relicensing and creating barriers to efficiency there. So there's probably a good 50 to 60 waivers that were put in place during the pandemic that we really want to hold on to. So that's a big effort, because the thought of going back to some of those ways is gonna, it's gonna hurt a whole heck of a lot.
I'll just jump on that bandwagon real quick, Michael. Michelle is spot on. What was allowed to happen during the pandemic actually closed a care gap for patients that otherwise we would have seen tremendous challenges with, even beyond the challenges that we face today in their complexity. For me, it's an awareness building campaign that there is going to be another pandemic. There will be another disease. And so this concept of helping consumers, the population at large, try to stay healthy means they shouldn't have to come to the hospital or to the doctor's office to do it. And it was the waivers and the use of technology that allow us to touch patients not in our setting and try to keep them healthier where they are. So that's going to be real critical for us as a society, I think, to consider for the long term.
Michael, on the question, I'd like to take the communications approach, and keeping in mind that we have the skills gap, that we are resource constrained in majority of our hospitals. From my perspective, it makes sense to create a problem-solving think tank, because you may not have the skill sets within your own health system, but you may have it at another institution. And if you create these think tanks where they bring in problems and you solve them together, you may be able to help each other out and leverage the community as a whole. And sharing is caring, right? So share the information and the know-how.
Kristen, how about the final word from you? Any other?
Yeah, I would think that the only other thing I would say is dropping some of those lines and looking to have a de-identified database where we can start to see globally trends and illnesses, right? So that we would know, and in the EU, we would know that there were folks getting sick with this respiratory infection in China, right? In ahead of time, and watching it kind of march across. So de-identified kind of patient records and being able to share those, because we're not truly sharing patient information, I think would be very helpful in kind of looking at things globally.
Well, I think you've all given us some great ideas just in that last couple minutes, but also across this hour. So I really want to thank you all, Kristen Miles, Machine Ahmed, Jeff O'Brien, Michelle Hood, for taking some time, for sharing these good ideas. And thanks to you in our audience for tuning in, for your good questions, and for your time today. You can learn more, as always, about US News live programs coming up at usnews.com/events. Thanks so much to our panel for joining us today, and for our audience for tuning in. Till next time.